Yeah. So thank you, Asim. And I'm so happy that you all are organizing such meetings. And it is important as a milestone in the history of Mahamana. And the reason is that ultimately we have three components in Tata Memorial Center: service, education, and research. Now, service, all of you are doing phenomenal, and I have highest praises for all of you. Everybody who is working in Mahamana, be it a consultant or resident, this is a phenomenal work that you all are doing in Mahamana. And as I gather, very soon the number of head and neck surgeries that are done in Mahamana are far more than what will happen in any center which has just completed 3 years of existence. So service is certainly good. Now, there comes the milestone in the history of any institution, what we call it education. And that education part actually gives a credibility to the institution. And I'm happy that now the education part is starting. Now, we are very fortunate that within 3 years of existence of this hospital, starting of this hospital, we already have two MCH surgical oncology seats which have been assigned. We have started the MD radiotherapy course also. And I'm very confident that in a couple of years, maybe we'll be able to start MCH in head and neck surgery in Mahamana. And third component, of course, will be research. And that research component is something that you all have already started. But very soon, I'm sure that you can be funded, you will be self-sufficient, you will be self-reliant, and you will be able to do path-breaking research because the population is different, the challenges are different, and certainly opportunities are different. And therefore, Varanasi will be Varanasi. Mumbai and South India, everybody will have their own challenges and possibilities that they are working with. So congratulations once again, Asim and the entire team, Ravi. All of you have done great work, and I'm here to support, and all of us are here to support you in your mission as we go forward. One most important thing for the youngsters is that this is the formative days of your life. Use it very carefully, use it very judiciously, use it for something that will give a significant rise to your portfolio when you actually go into practice. Because what happens that ultimately what matters is how strong your resume has become, and that can only happen when you have good publications, you have presentations, and of course uh, you have to think of various ways of apart from publication, your training opportunities or any other ways of improving your CV. So while those 2 3 years you are working or a couple of years you are working in any institution, you should be selfishly working on improving your resume, because all the hospitals, where it is Mahamana, whether it is Tata, whether it is any other hospital, the hospital will try to exploit you or getting the work done in terms of surgery or OPD or any other mandate that is given. But you as an individual should be very selfish, and you should ensure that how do you exploit the institution. And that is where sometimes you all fail. You all are so busy giving help to the consultants that you forget that ultimately when you go back home after finishing your training, what remains with you is the resume and the publications and several lines that are added to your resume. How many surgeries you did, how many you assisted, how many patients you see, that adds to your knowledge and skill. But ultimately, that can't add lines to your resume. Therefore, all of you should be very, very conscious in ensuring that you make the best out of your position as a trainee, as a fellow, as an observer to enhance your career. And Tata Memorial Center, fortunately, gives that platform. in terms of credibility, in terms of patient material, support for education and research. So all those are there. Use it and make sure that you make us proud. So again, let me congratulate Asim, Ravi, and Komal is there.
She is in
Komal
there.
Komal and I think Dr. Nisha is also there. Nisha is
yes,
there?
Nisha. Yes, sir.
Okay, okay. So all of you are doing an amazing work. So keep up the good work, Asim.
Thank you, sir, for the kind words. I'll now request the moderators of the session, Dr. Pankaj Chaturvedi, sir, Dr. Kranti Kumar. He is a consultant head and neck surgeon at Indo-American Basav Tarakam Institute, Hyderabad. Dr. Poonam Joshi, madam, she is the associate professor of head and neck surgery at Tata Memorial Center, Mumbai. And Dr. Devendra Gupta, he is a professor of ENT and head and neck surgery at Army Hospital Research and Referral, New Delhi. The case will be presented by Dr. Bhavya from Mahamana Pandit Madan Mohan Malviya Cancer Center.
Thank you, sir. Good evening to one and all the respected teachers. Myself, Dr. Bhavya, Senior Resident from Mahamana Pandit Cancer Center, Varanasi. I'll be presenting a case of oral cavity buccal mucosal carcinoma today. I'm presenting a case of 37-year-old housewife residing in Gorakhpur, Uttar Pradesh, who presented with a chief complaint of ulcer in mouth since 5 months. She presented with an ulcer in the left buccal mucosa since 5 months, which she noticed that the lesion was gradually increasing in size, initially from a small ulcer to the present size of 3 by 2 centimeter. It was associated with pain localized to the site of ulcer, mild to moderate in intensity, and aggravated on chewing, relieved with oral analgesics. Patient also complains of foul smell emanating from mouth, and also that she's unable to do her routine oral hygiene, maintain her oral hygiene due to pain. There's no history of sharp teeth.
Bhavya.
Yes, sir.
Perfect. So Bhavya, just carefully analyze these 2 points that you have shared.
Yes, sir.
The lesion is associated with pain localized to the site of ulcer, aggravates on chewing, and relieved with oral analgesic. If I just ask the significance of this history, you have seen this case. Now,
yes,
I'm just asking you, what is the significance of a painful ulcer in the tongue?
So painful ulcer, it could be an inflammatory or an infective ulcer, and also a malignant ulcer when it is extending or invading into the nerves with perineural invasion.
Excellent.
Can be suggestive of perineural invasion, sir.
Excellent. So what happens that you may have ulcers in the tongue. Usually in the beginning, they are painless. But once they become painful, they are deeply infiltrating ulcers, and therefore we are dealing with a locally advanced disease.
Yes, sir.
Correct? Because
yes,
unlike that, anything which is less than 1 centimeter will have this much of pain. Anything which is more than 1 centimeter, or maybe 8 to 9, 8 more than 8 or 10 millimeter will have this pain. And the second point that you said, foul smelling emanating from the mouth. What is the relevance of this?
So most of the patients, especially when they have a painful ulcer or any painful lesion in the oral cavity, they do not do their routine brushing and unable to take liquids or clean their mouth proper as a routine practice. So because of that, there's poor oral hygiene as well as superadded bacterial infections.
Excellent. So this again signifies that she will have perhaps ankyloglossia or painful deglutition because of the infiltrative disease. And
Yes, sir.
when she's having painful deglutition, she will keep the saliva and food residues in the mouth, which leads to this foul smell. That is
Yes.
one. The second, when you have deeply excavating ulcer, then in that there is a colonization of the bacteria, there is colonization of the food. So this both contributes to one thing, that we are dealing with a locally advanced tongue cancer.
Yes, sir.
Perfect. Go ahead.
There is no history of sharp teeth or toothache or loose tooth, earache, no history of any other swellings in neck. There's no history of reduced mouth opening or difficulty swallowing, though she gives history of painful swallowing because of cheek movements, associated pain. And there's no history of change in voice. There's no history of distant metastasis, suggestive symptoms like cough, hemoptysis, bone pain, loss of appetite or weight loss.
So Bhavya,
Yes, sir.
go back. Now, why did you take the history of sharp tooth?
Sir, chronic dental ulcers are also known to have a malignant transformation on a long term.
So what's the odds ratio, and which study that you can quote which says that sharp teeth or what is DMFT index?
Not aware, sir.
Or how do you are not aware of the study or DMFT index?
Sir, of the
Both.
study, sir.
Okay, so sharp teeth, they are known to have a chronic irritation. Can you tell me the odds ratio of maybe a range, how much contribution can happen because of the sharp teeth?
So sharp teeth in general, it causes a chronic irritation, mucosal erosion leading to dysplastic changes in the mucosa.
No, I'm talking about the risk. What is the odds ratio? Do you know what's odds ratio
Yes, sir.
or relative risk?
Relative risk. Yes, sir.
Okay, so you can note down and go back and study. These are very, very important things that you at this stage should know.
Yes, sir.
Okay, go ahead.
Sure, sir.
So Bhavya.
Yes, ma'am.
So another point I would like to add here is that if you see the patient gives a history of 5 months for an ulcer in buccal mucosa, which is easily visible. So one of the reason you said is because there was pain which was relieved with oral analgesics. So that could be one reason for the delay in presentation. So what
Yes.
are the other causes of delay in presentation when the lesion is so easily is accessible and can be seen by the patient or the attendants easily. So what is your idea about it?
Ma'am, most common what we see when we encounter with the patients and their attenders is that even though they have noticed the ulcer a while ago, they are reluctant to get it diagnosed with the cancer fear, or they have a misconception that biopsy will lead to increase. After biopsies, the lesions have progressed for many people. Most commonly, this is what we encounter in the OPD, ma'am.
So, Bhavya, I think if you are aware, we usually divide the delays into primary delay, and this is a kind of delays are of 3 types: primary delay, secondary delay, and tertiary delay in respect to presentation of patients into our OPDs. And this is the type of primary delay. So, primary delay is basically which is caused at the level of patient
Patient level.
Like you said, this is because of so many reasons. One you correctly said is that many a times patient they lack awareness. That is one of the important cause. The other, there are several reasons. There are a lot of publication. There is publication from TMH also, where we have seen that these patients are in denial. These patients usually belong to low socioeconomic status, and it is usually difficult for them to reach to tertiary care centers. I think in that respect, Mahamana is doing a great job because now it has reached to the patients themselves. So I think we need to be aware that there are a lot of reasons why these patients are presenting to us so late, even though they are easily visible.
Yes, ma'am.
Go ahead.
She is also a known pan chewer for 5 years and has stopped since 3 weeks. There are no other addictions, no comorbidities or prior treatment history, and there's no family history of any malignancies. Coming to the general examination, a middle-aged, well-oriented female, moderately built, well-nourished and hydrated, with a BMI of 26.5 per kg meter square, a performance status of ECOG 0, no signs of pallor or icterus, cyanosis, generalized lymphadenopathy, or pedal edema. On local examination, oral cavity, inspectory findings, mouth opening was 3 fingers, poor oral hygiene and stained teeth attributed to her habits of pan chewing. Halitosis was noted. An ulceroproliferative lesion was noted over the left buccal mucosa, measuring approximately of 3.5 by 2 centimeter, with irregular margins, everted edges. The lesion was seen extending up to the upper and lower GBS, but though not involving the GBS, gingivo-buccal sulci. Anteriorly, the lesion was falling short of oral commissure by 1.5 centimeter. Posteriorly, the lesion was extending up to the level of third molar. RMT was free. Skin appeared normal. Rest of the oral cavity appeared normal.
So, Bhavya,
on palpation, there was tenderness and the lesion bleeds on touch. Inspectory findings were confirmed with respect to the extent of lesion. There's a palpable induration was noted of around 5 millimeter from the wrist. Yes, sir.
There is a question from Poonam.
Sir, can you, thank you, sir. Bhavya, can you go back to, previous slide? Can you hear me, Bhavya?
Yes, ma'am.
So I wanted to ask you that you have written this mouth opening is 3.2 centimeter.
Yes,
what does convey? What is the meaning of 3.2 centimeter? What is the interpretation?
Ma'am, I have mentioned the interincisal distance, ma'am.
What have you used for measuring the interincisal distance?
Ma'am, routine scale I have used, ma'am.
So what do we, ideally, what should be used, Bhavya?
Usually the finger breadth, by number of fingers it is measured.
So I think the ideal way to measure it is the vernier caliper, which is described in literature, but I understand that most of the places, even at TMH, we are not using it and we use a routine scale like you have used it. I think finger measurement may not be the ideal way to do it. So the next question here is, what would be the cause of, will this mean that the patient has trismus, Bhavya?
Ma'am, she does fall into grade 1 trismus, but because of pain, she was unable to open mouth, ma'am.
What are the causes of trismus in a case of carcinoma buccal mucosa?
Ma'am, in this case, it is because of the superadded infection or involving the muscles or the neural involvement. And other than that, muscle spasm or involvement of muscles by the tumor can cause like pterygoid or masseter, and involvement of mesenteric lesion extending to RMT can cause pain.
Correct. So usually the trismus that will usually you will see in advanced cases, and one of the cause can be oral submucous fibrosis. I think that you have not mentioned it if it is present or absent, and that because she is a pan chewer, and I assume that with the pan she was taking probably tobacco and areca nut, and I think here you need to mention about the presence or absence of oral submucous fibrosis.
Ma'am, rest of the oral cavity mucosa was supple. There were no signs of oral submucosal fibrosis, ma'am.
Okay, thank you. Go ahead, Bhavya.
Hello, Bhavya, hello.
Yes, sir.
Just taking the oral submucous fibrosis further, is there any significance, about the oral submucous fibrosis and the prognosis of the patients of buccal mucosa cancer, oral cavity cancer?
Sir, oral submucosal fibrosis, according to WHO, it has been labeled as a potentially malignant lesions of oral cavities, so one of the potentially malignant lesions, with a conversion rate of at least 1.3% per year into a malignant lesion. And if a patient presents with a oral cavity cancer and also has oral submucosal fibrosis, the chances of a patient developing a second site primary or a synchronous or a metachronous primary is also more, so the patients are kept in follow-up, sir.
Right. And regarding the prognosis of the present lesion, we are not talking of the second primary. Like there are two patients, one has got oral submucous fibrosis with a cancer and one is without oral submucous fibrosis and cancer in terms of local spread, nodal spread.
Sir, in fibroid matrix, there are articles on tumor microenvironment where the stromal type in oral submucosal fibrosis, where there's a fibroid matrix, and that will prevent the tumor budding and also the invasiveness of the tumor.
Right.
However, the myxoid matrix has a propensity that it favors extensive tumor budding and also more chances of lymphovascular invasion and lymph node metastasis. Sir.
Right. I think there is a paper from Tata itself regarding the oral submucous fibrosis and prognosis, and the oral submucous fibrosis patients do better than the other subset.
Yes.
Go ahead.
Bhavya, am I audible?
Yes, sir. Yes, sir.
Any grading system of the submucous fibrosis?
Oral submucosal fibrosis, there's Pinbog staging for Pinbog staging and even Kanna staging, sir.
So
Pinbog staging classifies it as early vasculitis changes and early fibrosis and stage of complications. Sir.
Yeah.
I think, Bhavya, there are a lot of classification even for trismus, but I
Yes,
think, so there are various ways to grade the type of trismus.
Yes, ma'am.
So I think similarly, I think that's for OSMF also. I just wanted to ask you one question that in this present lesion, you have described that the lesion is involving the basically the left buccal mucosa and it is upper and lower GBS. Does it have any implication on your further plan or management regarding the investigations? So like you said, the lesion is not involving the upper and lower GBS. If it would have been restricted to buccal mucosa, will that make any difference to your further planning?
Ma'am, planning definitely, ma'am, especially even though the prime investigation, we will go with the contrast enhanced CT scan, but the surgical planning would alter if it is involving the upper and lower GBS, or even if it's abutting the upper lower GBS or RMT region, ma'am. Instead of a wide local excision, I may have to offer the patient for even marginal mandibulectomy or upper alveolectomy if as a board to take adequate margins.
Okay, Bhavya, I think we'll go ahead and we'll see the next slide. We'll discuss it.
On palpation, the lesion was tender, bleeds on touch. Inspectory findings were confirmed with respect to the extent of the lesion. Palpable induration was noted of around 5 millimeter from the visible extent of the lesion. On palpation, both upper and the lower gingivo-buccal sulci, the gingivo-labial sulci and floor of mouth were free. Skin was not involved. Neck examination, there were no palpable nodes. Hopkins examination, bilateral vocal cords were normal and mobile. There were rest, no abnormalities or no lesions were noted. ENT examination, scalp and spine examination, cervical spine examination was normal. Coming to the systemic examination, respiratory system, normal vesicular breath sounds were heard bilateral and no adventitious sounds.
Oh yeah, in palpation, did you mention about the thickness or the thickness of the tumor, which is actually easily accessible in buccal mucosa, especially in the anterior lesions? So you have mentioned the dimensions of the tumor in inspection, and in palpation we can find out about the infiltration, depth of infiltration. So did you measure that, and what is the significance?
Sir, thickness of tumor and depth of invasion has been added in the AJCC 8th edition for grading of the primary tumor, the T staging of the tumor, sir.
Right. So in palpation, we can have some idea about the depth of invasion, although it is not accurate.
Yes, sir.
So Bhavya,
Yes, ma'am.
Do we need to do Hopkins examination in a case of CA buccal mucosa like this, which is you said is a early buccal mucosa? Why do we need to do a Hopkins examination for the same?
Ma'am, I have included it for completion of the examination purpose, and also because it's an oral cavity cancer, and especially it would be helpful for a smoker, not a tobacco chewer, and a smoker to look for a second primary.
So what is the annual rate of second primary tumors, development of second primary tumors in oral cavity cancers?
Ma'am, around 3% per year in oral cavity cancers.
So it's around 3 to 4%. And usually in patients who are habitual with tobacco, which is either smoked tobacco or even smokeless tobacco, it is recommended to include at least the upper airway examination, because it has been found in a few studies that the upper airway examination was found to be the detection of primary in the upper airway was easier as compared to in the lower airway. And moreover, nowadays we include CT scan for the lower airway, CT chest for the lower airway. So a Hopkins examination is good enough to rule out a second primary tumor, which is simultaneous, we can say, or asynchronous.
Yes.
Correct. Go ahead.
Ma'am, to summarize, a 37-year-old lady, known pan chewer for 5 years.
So,
presented with an ulceroproliferative growth involving left buccal mucosa of 3.5 by 2 centimeter size with everted edges and palpable induration. Both the upper and the lower gingivobuccal sulci, retromolar trigone area, floor of mouth, skin were not involved, and no significant cervical lymphadenopathy.
So Bhavya,
yes, ma'am.
Would you like to tell me that a bit about the how does a pan chewer will develop cancer? Because we are assuming that the reason for her to develop cancer here probably is the pan chewing, correct? Because
yes,
there are several reasons, like several causative factors for development of oral cancer, and in this case, you have given us history is suggestive of pan chewing and no tobacco. I don't know if there is associated tobacco with that, because that would be important point to know.
Yes, ma'am. The patient gives a history of pan chewing, which is the one with the tobacco. The pan chewing per se has two different forms, one without tobacco, that is betel quid, and pan chewer with tobacco. And in a case of a pan chewer with tobacco, the constituents, the main carcinogens include the arecoline, tannins, and chewable tobacco form N-nitrosamines, ma'am. Nitroso-nor-nicotines, which cause DNA mutations and DNA adduction or methylation, leading to irreversible DNA repair, DNA damage, and dysplasia events, ma'am.
So, perfect, Bhavya. So, I think you're right that pan, like you said, this pan probably is with tobacco, and probably along with the arecanut, you said. So, this tobacco basically has tobacco-specific nitrosamines. It has a lot of hydrocarbons. It has aromatic amines. It has other carcinogens. So, in smokeless tobacco, there can be up to 16 carcinogens which have been found till now. The researchers have found, and in the smoked tobacco there can be up to 60 carcinogens. So this can contain so many carcinogens, and along with the ericatin, which is the important component, the active component of arecanut, which causes cancer, is associated with the pathogenesis of cancer. Like you rightly said, it causes mutation at the genetic level, mainly P53 mutation. There is formation of DNA adducts. Then there is formation of reactive oxygen species. So they lead to these reactive oxygen species, ultimately lead for the activation of these carcinogens. And these carcinogens, when they react with the tobacco, with the DNA, they make them mutated. and the normal function of cell growth, apoptosis, or the cell cycle, it gets disturbed. And this leads to the process of carcinogenesis. So I think that is that's the way it happens. So what is the stage of this cancer?
Ma'am, it's clinical staging T2, N0, M0, ma'am. The person, we have done a contrast enhanced CT scan as well as NCCT, non-contrast CT thorax for the patient.
Okay.
Bhavya, why do you want to do the CT scan in this patient?
Sir, in this patient, because the lesion was abutting the gingiva buccal sulci, both upper and lower, I wanted to know for the bone erosion, if at all, if it's present, sir. And also the extent of the tumor.
Because you said the GB sulcus were free.
So on palpation, it appeared free. On palpation, it is free, but sir, if my surgical plan would change if the CT shows involvement of GBS as well as bone erosion, if at all present, sir.
Okay. And will it upstage?
Yes, sir. Involvement of bone would make the disease as T4A.
Where is the exact location of the lesion? It is close to the RMT, right?
Sir, RMT region is free, sir.
Free.
Yes, sir.
Okay. Anything else you wanted to see on the CT scan? Will it change your management?
Sir, one is skin involvement I would like to see.
But that is usually seen by clinical examination, right?
Yes, sir.
Mm.
And the other is involvement of muscles like pterygoids or masseteric muscles, and also ITF involvement, sir.
Okay.
One point, doctor, I would like to mention is that when you examine a buccal mucosa lesion like this, you also need to be very clear on stating that the skin may not be involved, but on a bimanual palpation, whether the induration was palpable in the skin, because as we know, it's very difficult. Even the fat standing on, no imaging can actually tell you whether you will get you will be able to get the third dimension there. So a proper palpatory finding, okay, of the skin may not be involved, but you need to document whether there is induration palpable. If the induration is palpable, again, your surgical plan will be mostly to excise that much of skin there. So that information can be documented, I think.
Okay, sir.
So, Bhavya, that's a very valid point. So, in these cases of CA buccal mucosa, so like you rightly said, we need to see if there is infiltration of the adjacent bones. Along with the bone, the infiltration of buccal mucosa cancers to the skin is a bit early. Because can you tell me the layers from mucosa to skin? What are the various layers of cheek?
Ma'am, from inside out, it's the mucosa, submucosa, the buccinator muscle with the buccopharyngeal fascia, the buccal fat pad, as subcutaneous tissue, and skin, ma'am.
So, Bhavya, so whenever we have a lesion of buccal mucosa, which is reaching till the buccinator, there is a barrier. But the moment it reaches the buccinator muscle, that barrier is lost. Like you rightly said, in the buccomesenteric region, or you can see the buccal pad of fat area, basically there is no barrier. The moment it crosses the buccinator muscle, it very early reaches the subcutaneous tissues. So I think that is a very valid point stated previously by the moderator, whenever you are mentioning a buccal mucosa lesion, we have to mention, I think you have mentioned it in the CT findings, that the skin is not. Moreover, on CT scan, CT is not a very sensitive imaging modality, or in fact, there is no imaging modality to tell you rightly that if the skin is involved. Because in CT, you will just be able to see some subcutaneous fat, maybe there may be substanding, but that may not be right always, and it does not have much of sensitivity. I think and you have to see for the induration or the pudgy orange.
Yes.
look at this.
Bhavya, about the CT scan, any particular technique, especially for the buccal mucosa cancer?
Sir, buccal mucosa and buccal mucosa, we usually take a puffed cheek contrast enhanced CT, sir.
Right. So it is seen in your scan also.
So Bhavya, is there MRI has any incremental value over CCT?
Ma'am, MRI, especially in this case, when there is a confusion whether skin is involved or how much of depth of the tumor it is, MRI would add on points regarding the depth and superficial lesions or involvement of nerve as well.
So Bhavya, I am not sure if MRI is also very sensitive for skin involvement, but naturally we always say that it has a better soft tissue delineation and over CCT, and it is usually complementary to CT scan.
Yes.
And because you are saying it is an early lesion T2, so in this case, most likely a CCT should be sufficient, and MRI may not have any incremental value of
Add
over
on points.
Bhavya, what about, can you tell me about how do you, like, if you get a report, if the radiologist says that there is a 1.1 centimeter level 1B node, okay,
Yes.
so clinico-radiologically, how do you have to interpret it? Like, can you tell me some radiological features of a neck, of a metastatic cervical lymphadenopathy?
Sir, so nodes, usually the height and width of the nodes are also mentioned. Plus, if there is any perinodal extension, presence of necrosis, and the size of nodes, sir.
So necrosis and size of the node, that's all this what the what the radiologist sees. Are there any other features?
Not that I'm aware of, sir.
Okay. So basically, it is not only the size, as you said, size is important. Okay, and size at different level there are different cutoffs. Okay, if in level 1B the cutoff is different, level 2 there's a different cutoff of how to differentiate size wise between a reactive node versus a query metastatic node. Secondly, you need to see the shape. Okay, generally you will have a reactive node will be more ovalish. Okay, and a more rounded node will be more of a more showing metastatic. Small nodes may not have necrosis all the time. Okay, but a good radiologist will see other factors also. As you said that a perinodal extension is again a very advanced feature. You will not be able to see it very in all cases. Okay, and especially when you want to when you have a T2 lesion, okay, with a clinically N0, and you want to probably see for those nodes. This is basically academic to see for whether there are any metastatic nodes in the neck by CT. Do you have any idea on the sensitivity and specificity of CT scan for detecting nodes in a N0 neck?
Sir, in an N0 neck, there is a trial by Liao et al. Which compares 4 modalities that includes ultrasound, CCT, MRI, as well as PET-CT for nodal sensitivity and specificity, identification of nodes. And all 4 modalities, they found an average sensitivity of 60 to 70% and a specificity of 70 to 80% for all 4 modalities. Not much of a significant difference, sir.
So it is a meta-analysis. It is not
Yes.
Okay, but it has very good findings. Okay, if you can go through the entire report. That's a valid point. Yeah.
So Bhavya,
Yes, ma'am.
so what is the occult metastasis rate of nodal metastasis for a early buccal mucosa cancer like this? Because you said radiologically it is N0. So what do you think would be that?
Ma'am, for buccal mucosa, early tumors, there's an occult metastasis percentage range of more than 20%, mentioned in various studies by Gendin as well as O'Brien article and also an article of N0 study by TMH itself.
That N0, I think most of the patients are CA tongue. I would say
Yes,
we
ma'am.
have a paper by Dr. Walbekar by the same group only, and they have this early tumor, early buccal mucosa cancer specifically, more than 200 patients. And
Yes.
there also, I agree with you that the metastasis rate is around 24%. And most of the series, I think from MSKCC also by DRs, also has shown it to be around 26%. So it
26%.
usually, yeah, so it usually varies between 20 to 30%. Okay, so I think
Yes,
we'll go ahead with the presentation. So next slide will go.
Ma'am, the workup part of it was. Ma'am, coming to the workup, other than the routine labs, I would like to get a biopsy as well as a contrast enhanced CT scan of head and neck with an NCCT thorax. And in my case, it's a case of T2, N0, M0. I would go ahead in giving option to the patient on surgical management with or without adjuvant radiotherapy in the post-op period, ma'am.
So Bhavya, when we are
Yes, ma'am.
because we still are left with some time also. So whenever we are doing biopsy of these lesions, what point should we be keeping in our mind for residents like you and for others? I would like you to enumerate. So doing a biopsy for a buccal mucosa lesion, what all point you should be taking care of?
Ma'am, buccal mucosa lesion or a tongue lesion, oral cavity, any site tumor, the biopsy has to be done from the most representative site of the tumor and not from the central necrotic area, as it will not yield the biopsy adequate or appropriate biopsy result.
So how do you define a representative area, Bhavya?
And ma'am, most common for a buccal mucosa, it would be from the edge of the ulcer edges or the lesion edges where maximum proliferative activity is noted.
Okay. So what else? Would you prefer a punch biopsy or you would prefer an incisional biopsy? And
Ma'am,
why
incisional biopsy would be preferred.
Why it is like that? Why would you prefer an incisional biopsy over a punch biopsy?
Ma'am, punch biopsy, if it is taken from the proliferative part of it, that does not include the subepithelium. So the pathologist will not be able to give whether there is invasion or not. So they end up giving a hyperplastic squamous mucosa as a report. So if it's an incisional biopsy, they will have the subepithelium, which they can compare and provide on the invasiveness component of the lesion.
Very good, Bhavya. Perfect. So I think you already rightly said that in incisional biopsy, we will be taking a deep biopsy where we'll be taking a part of tumor along with normal mucosa. So that the interface between the normal and the abnormal can be easily appreciated, and they can see the infiltration of the lamina propria adequately to deem it as a invasive carcinoma. Very good.
So, regarding the biopsy, sorry.
Yes, sir.
So regarding the biopsy only, do you sequence your biopsy in terms of you doing the imaging first or biopsy first or both together? Any thoughts on this?
Sir, in our center, we are practicing biopsy first because we would like to know what we are dealing with. If it's a tumor, should we have to go further with the radiological workup or not? But there is a controversy on whether the biopsy has to be done or first or imaging, because biopsy causes a little amount of tissue edema, which may interfere with the radiological findings, especially in case of tongue tumors.
Right. Right. So it is actually a practical question. Sometimes you have a long waiting list for the imaging. In that case, you do a biopsy first. And as you rightly said that you want to know the actual reason for the lesion. So doing a biopsy first. So actually it is, this question is not very relevant, but we should be very clear, we have our residents, ENT residents, general surgery residents. So there is always a confusion that we should do a biopsy first or a imaging first. So we should be doing a biopsy first, or if imaging is available immediately, then why not? If we can do an imaging within a day or two, then we can do an imaging also before biopsy.
Yes, sir.
So, Bhavya, why do you want to do the metastatic workup in this case?
Sir, in this case, we have done it for a complete workup sake. Otherwise, for a T1, T2 lesion of a buccal mucosa with an N0 neck, as it is not mandatory to go with a metastatic workup, sir.
So what is the incidence of distal metastasis in a?
So the incidence of distant metastasis in the absence of neck nodal mets is less than 4% extra thoracic metastasis.
So she is having a habit, right?
Yes, sir.
So could you elaborate the concept of field cancerization?
So the concept of field cancerization was first proposed by Slaughter, where the fact that any habit like tobacco or smoking habit causes a generalized insult to the whole mucosa of the upper aerodigestive tract. So that causes mutations, and there are two hypotheses where a person can get simultaneous primaries or multiple primaries. One is either by multiple events occurring at the same time throughout the insulted mucosa leading to multiple primaries, or a single clonal event which will have a subepithelial or intraepithelial migration leading to multiple primaries.
Seed soil theory. Right. You can go ahead. Right.
So, Bhavya, how will
Yes,
you
ma'am.
manage? What will be your extent of surgery and the approach?
Ma'am, for this case, since it's a well localized buccal mucosa lesion, I would go ahead, or I would like to offer the patient with a wide local excision buccal mucosa with selective neck dissection level 1 to 3 and primary closure.
Primary closure.
Primary closure, or if the defect is bigger, we can use a buccal fat pad to close the defect, sir.
So, Bhavya, you said you will do buccal mucosa wide excision. That will include mucoperiosteal stripping of upper and lower GBS also?
Ma'am, if we're getting an adequate margins, we need not include, but for the margin sake, the mucoperiosteal stripping can be done of both upper and lower alveolar ridges.
Okay. And you will be doing a neck, the selective neck dissection.
Selective
So
neck dissection.
what will be the extent of what all levels you'll be including in your sentinel, selective neck?
Ma'am, since it's an N0 neck, I would like to include level 1, 2, and 3, ma'am.
Okay, so why not level 4? Because that's the routine we follow for tongue many times. So any reason you will bring level 4?
Ma'am, in presence of N0 neck, the chances of occult metastasis in level 4 is less than 9% in oral cavity cancers.
You're right,
So
ma'am.
level 1 to 3 should suffice for the neck dissection part of it, ma'am. There are higher chances of occult metastasis in 1, 2, and 3, and less for 4, like around less than 9%, and 5 is less than 2%.
Correct. So I think that bias data, the question which has been put is mainly it was for tongue cancers, and it was regarding the skip metastasis to level 4. And
Yes,
I think the skip metastasis rate was around 15 to 16% in that paper. But however, I think most of the studies which have been conducted after that have shown it to be much lesser. And moreover, in buccal mucosa lesions, in fact, the involvement of level 4 in absence of nodes at other levels, like you rightly said, is minimal. I think it is even less than 9%. And so the first echelon is level 1B, and then followed by level 2. So if you are doing your dissection, which involves level 1, 2, and 3 in an N0 early buccal mucosa cancer, that usually serves the purpose. But Bhavya, I think all of us do not agree with this point that this lesion can be closed primarily. So what are the issues if you close it primarily?
Ma'am, primary closure, because the lesion is almost around 4 centimeter, primary closure may lead to scarring and difficult mouth opening or reduced mouth opening in the post-op.
So what margins you will take, Bhavya, here for this lesion? What mucosal margins and soft tissue margins you will be taking, Bhavya, here around the tumor?
Ma'am, mucosal margins, including up to the gingival, the mucosal margins of 1.5 to 2 centimeters should suffice, ma'am. And if involving soft tissue, that should be around 2 centimeters.
Why do you want to take a 1.5 to 2 centimeter mucosal margin, Bhavya? What is the whole length of buccal mucosa? There is a concept of tumor shrinkage, right?
Yes, sir.
2 centimeters will be too much. So how much the buccal mucosa has got a shrinkage capacity compared to the tongue?
So buccal mucosa shrinkage capacity is around 20%, 20 to 30% intra-op, sir, and an additional 20% by formalin.
But we don't aim to take 2 centimeter margin.
So, Bhavya, I think there was some literature earlier, I think when I was your age, then we were reading and there was some literature to support that for tongue cancers because they are known to have be rich in lymphatics and they have rich vascular supply. There was some literature to support to have 2 centimeter margin. But over the years, we have seen that a negative margin of 5 mm or more is sufficient to achieve good local control rates. Okay, so for that, so usually to achieve a 5 millimeter margin, free margin, you usually take 1 centimeter margin. So that's the gross 1 centimeter margin because the previous moderator, like rightly said, there is contraction of margins because if you have retraction or contraction of margins post resection. I think there is paper from Tata only by Dr. Rajesh Mistry and another paper is on, I think, canine, the dogs. So that has shown that there can be, even the buccal mucosa shrinkage is actually less than the tongue, but still there can be 2 to 3 mm shrinkage of buccal mucosa lesions once you dissect it. So you have to add that 5 mm plus 3 mm. And in fact, we have a publication from Tata again with Pankaj Sir's group again, with Saurabh Datta being the leading author, where they have shown that if the gross margins are more than 7 mm, then you achieve good local control. So what I would do here is, whenever you are taking margins, you can keep it around 1 centimeter so that your gross margins come around 7 mm. So I think that solves that mathematics. So if you take 1 centimeter, 2 to 3 mm, you have this retraction of margins, it comes around 7 mm, and with a gross 7 mm margin, you achieve good local control.
Considering margins in the ulcer, now can you revise your reconstruction, primary closure or something else?
So wide local excision buccal mucosa with selective neck dissection level 1 to 3 and buccal fat pad buccal flat pad closure. Or we can use a split skin graft as well, sir.
What are the problems with this?
You are focusing more on oncological concept, but what about the functional aspect of the patient in the post-operative period? What is the mouth opening of this patient now?
So 3 fingers, sir.
3 fingers, right? So putting a skin graft in the buccal mucosa area where you create a raw area of around 4.5 centimeters. After excision, you expose all the masticator muscles. So how do you expect the healing to happen if you put a skin graft?
So a lot of fibrosis is noticed in the muscles when muscles are exposed after excision, sir.
So what if this patient comes back to you after 3 months? If this patient goes for radiation, so what is the mouth opening of this patient then? How are you going to examine this patient? So not only the oncological, but still we need to focus more on functional aspects of this patient, right?
Yes, sir.
So you want to change the reconstruction plan?
Especially for the early cancers, the reconstruction and the quality of life should be focused more because they are going to visit you more frequently and more longer. Their long-term quality of life should be kept in mind while considering reconstruction.
Yes. So we can also use free flaps, the free radial forearm flap for the buccal mucosa defect, since the defect is going to be more than 4 centimeter, 4 to 5 centimeter.
Are there any other alternate flaps rather than radial forearm? Because radial forearm has got its own implications in terms of morbidity. She's a 37-year-old lady.
Yes, sir.
Right?
Yes, sir.
So you have heard about lateral arm flap?
Lateral tongue flap. Yes, sir. Yes, sir.
So for this patient, ALD, if she's having a bulky thigh, this would be little more overcorrection.
Okay.
So we can use lateral arm flap too.
Okay.
Can we use submental flap here?
So submental flap also. Yes.
So coming to the reconstruction ladder, what do you want to use for this patient? You told us that we wanted to use it a free flap, right? Then coming to the other regional flaps.
A submental or a superficial temporal artery based flap, sir.
Superficial temporal artery based flap. Means
Submental or a superficial temporal artery based flap.
you mean to say temporalis muscle flap?
Yes, sir.
Your coronoid probably will be in the margin, right?
Coronoid will not be the margin, sir.
Sure. Okay, go ahead.
So Bhavya,
Yes, ma'am.
so what I would say here, I think the point you would put forward is that buccal pad of fat can be one option, and even skin graft can be one option, because they all are part of that reconstruction ladder. And I think that the ideal reconstruction would be a free flap. But as we know, because of the workload, that may not be always possible for us due to the resource constraint situations. So if we talk practically in that sense, I would say that particularly in this case, probably it will not be a great idea to use a skin graft in this case, because you said that patient has trismus. And another thing I would like to point out, Bhavya, because initially you said it is 3 centimeter, then you said 3 fingers, but they are not synonymous. So finger and centimeter will not be the same. So I think we should stick to centimeter, because that gives us some more objective assessment. And for this case, I agree that as Dr. Deepak has written, that for this case particularly, this buccal pad of fat and SSG is not a great option, like we discussed, because of this large size of the lesion, and you'll be removing most of the buccal mucosa, and there is already pre-existing trismus. But in certain cases where the mucosal involvement is small, and you can leave behind a lot of mucosa, and the defect is, I can't quantify that, but usually for small buccal mucosa defects, it is okay to leave it behind for secondary intention healing, where there will be some contracture like in SSG. So I think that is one option, but not for this patient. And moreover, the defect is a large defect. So the defect here, the reconstruction, like the other panelists and moderators said, the ideal would be to do a free flap. Even FRAF would be an option, free radial artery forearm flap, but because of the hand morbidity, usually it is not preferred by the plastic surgeons nowadays. A thin ALT would be another option. And I think there are a lot of local flaps which can be used here, but I would not be very comfortable doing submental flap all the time. Because it is a buccal mucosa lesion, and level 1B is the first echelon, but that can be debated, because there are a lot of studies which suggest that it is oncologically safe, and there are some studies which have shown that it is not oncologically, it is oncologically unsafe. So I think that one thing is clear, Bhavya, here is that in a patient who has trismus and has resection of large part of buccal mucosa, you should not be doing it primary closure, leaving it raw, or putting a skin graft, because all these things will lead to contracture because of the secondary healing, and you need to put a flap there. That is a different thing, that what flap you can put, but you need to reconstruct it with a flap.
Okay, ma'am.
How do you want to follow this patient? Suppose this comes as your pathologically T2, N0, M0, you do not want to give any adjuvant treatment. What is your follow-up policy?
So follow-up in the initially up to 6 months for every 6 weeks to 8 weeks. And after 6 months, the patient can be followed 3 monthly up to 3 years and 6 monthly for up to 5 years and yearly thereon. For both local examination as well as scans indicated only if symptomatic or suspicious of any lesions.
So, Bhavya, is there
Yes,
any non-surgical way to treat this lesion?
Can you repeat the question, ma'am, please?
There can be a non-surgical modality to treat this patient of early buccal mucosa cancer?
Ma'am, there is a trial or a study conducted on brachytherapy for buccal mucosa lesion, which is not reaching the RMT or not involving RMT region. But the study has found that for early lesions of buccal mucosa, T1, T2, it has equal survival and local regional control and recurrence chances.
So why don't we use it so often, Bhavya? So you said the local regional control rates are similar, even in fact the OS is similar, and you said brachytherapy has been used in earlier years, but we are not using it routinely. So what is the prerequisite for using a brachytherapy treatment for buccal mucosa cancer? What are the pros and cons?
Ma'am, pros is that the surgical morbidity would be reduced, but we are giving surgery as the first option because along with the surgery of the primary lesion, we can also treat or address the neck as well. And after brachytherapy, the neck recurrences have been found more. And since the occult metastasis chances is more than 20%, trials do recommend doing a selective neck dissection, which cannot be done if we are doing brachytherapy as a prime modality treatment.
So excellent answer, Bhavya. So I think I will just summarize this. So do you think this patient is an ideal candidate for, if suppose there is no nodal metastasis and we feel that it can be treated, but per se, as per the primary lesion also, can this be treated with brachytherapy? What goes against that?
Ma'am, one is the lesion size, it's around 4 centimeters. And
Go ahead, Bhavya.
That would be the major disadvantage of giving interstitial brachytherapy. Like if the lesion, there is a remnant lesion, then again, she'll have to undergo a surgery for addressing both the primary as well as neck again.
So Bhavya, so you rightly said, most of the time the size of the lesion is important. Like usually brachytherapy, interstitial brachytherapy is preferred for smaller lesions, like up to 3 centimeter. Then the second point is because here your lesion is going towards upper and lower GPS. So naturally, if you put a brachytherapy, this module into that buccal mucosa, it is going to radiate the surrounding bones also. So then again, it is not recommended. The third point is that this patient has trismus. So the placement of the brachytherapy instrument or whatever the radiotherapy module would be difficult in a patient who has limited mouth opening. So that will be a problem. And fourth, which is most important, which you rightly said, is that we won't be able to address the neck in a patient like this, which is on the upper side of T2, where the chances of occult nodal metastasis is as high as 20 to 30%, is around 26 to 20.
Can we give EBRT to this patient, fractional beam radiotherapy?
Sir, as a prime modality treatment?
Yeah. alternative to the surgery? And if not, what is the evidence?
So there's an article by O'Brien where T1, T2 lesions of buccal mucosa has been treated with surgery as well as EBRT, but they have found the even though there is a good loco-regional control, the complications of radiotherapy like xerostomia and long-term health related quality of life impairment is more with EBRT as a treatment, sir.
There is a very good paper by Robertson. So it was a randomized control trial where they tried to compare surgery RT versus RT. There was a premature closure of this trial because combined modality treatment has got better results. So, and even the NCDB database which has come, where 20,000 odd patients have been included in the study, it shows that surgery is the better modality compared to radiation in early lesions. Okay?
Yes, sir.
So Bhavya,
Yes, ma'am.
is the role of chemo prevention, like you said, that these patients are at increased risk of second primary tumors, metachronous also. So is there any role of chemo prevention in these patients? Because you'll be following, like we discussed, that this is a patient where the survival is better, and we expect that he will be coming for follow-up. So do you think we can give him, so what is the role of chemo prevention in the follow-up in such patient? Do you think there is any role in follow-up?
Ma'am, I'm not aware of the evidence regarding this, ma'am. For potentially malignant lesions, they have shown a proven benefit, but not aware if we can use it as a follow-up for already operated or treated patients, ma'am.
So, I think for potentially malignant lesions also, there is some data to suggest that the retinoic acid specifically has been found to be useful, but mainly for the leukoplakia.
Leukoplakic lesions.
Once this drugs were stopped, means the drug was stopped, there was rebound this increase in the size of the lesions, and in up to 50% of the cases there was this increase in the size of the lesions, and there was toxicity mainly to liver. So, and there has been lot of studies, and there has been use of lot of other agents, like even I think there is use of turmeric in lot of studies.
Curcumin extracts, yes.
Even from Tata Hospital, there is use of green tea. So this chemo prevention, there is use of interferons, but still most of them are in a trial phase, and we don't have still a very robust data to suggest that if we should be using them in the for prevention of SPTs or in potentially malignant lesions. So still it is in a trial setting. So it's not a used in routine.
So how do you decide about adjuvant treatment in this patient?
Sir, if the histopathology report, the final HPR shows factors like positive nodes, or if at all, if there is a lymphovascular or perineural invasion, then post-op adjuvant radiotherapy would be offered, sir.
So is there any evidence to justify for perineural invasion? Exclusively, the patient is having only perineural invasion, and if you found it comes out to be a T2N0, well differentiated, margins are free, PNA positive.
Not aware, sir, only for perineural invasion.
So you need to read these two topics like perineural and pattern of invasion, which is coming up now.
Yes, sir.
Hmm?
Yes, sir.
Yeah.
So, Bhavya, I think we are left with some time. So, I would just ask you if this would have been a carcinoma of RMT or reaching RMT, would your treatment would have changed or your planning would have changed a bit as compared to buccal mucosa alone lesion?
Ma'am, the surgical planning would change in term of, instead of a wide local excision, if it's an RMT lesion, we would have to go with composite resection, which may involve the upper as well as the mandible resection as well, ma'am. Like a posterior segmental mandibulectomy with upper alveolectomy, depending on the involvement of bone.
Okay. So I think by this, why I'm asking this question, Bhavya, is I just want to bring to your notice and to the notice of other students also that when the lesion, buccal mucosa lesion reaches the RMT, that is a different subside. Usually, once the lesion reaches the RMT, the lesions become more aggressive in terms of, because you know that RMT lesions, because the RMT is at the anatomic crossroad of nerve and muscles. So in those cases, when the RMT is involved, there is a higher, or the lesion is sitting on the rectomolar trigone area, there is a higher risk of involvement of nerves. Like the previous question, there can be early involvement of nerve, because you know that the location of the inferior
alveolar and mandibular.
The
Inferior
myelohyaline.
alveolar and mandibular nerves of trigeminal.
So that is a branch of mandibular nerve, which is V3. So because it lies in the in that area close to the RMT, because as per this thing, and moreover there is this medial pterygoid muscle which can easily get infiltrated by the in the RMT lesions. So so you have to be extremely careful, because once the lesion reaches the RMT, from the RMT it can go to the muscle, it can go to the nerve, or in fact it can reach the palate also. So, and it can go to the pterygomandibular raphe, and so the extension becomes quite easier and extensive. So that's the important take-home message, that lesions which are RMT lesions, we have to treat them with more aggressive plan, because they are known to spread fast because of their location, and even the bone erosion is early. I think we are on time.
So what is the implication of supranotch and infranotch, as madam has raised this now? So would you like to elaborate
Yes.
about supranotch diseases and infranotch disease?
So there's an article by Liao et al. Where the infratemporal fossa involvement, or the extension of the disease of buccal mucosa involving mesenteric space, has been divided based on a transverse line which divides along the coronoid notch, either a supranotch or an infranotch disease. Infranotch disease is usually an operable disease and can be removed with clear margins. The problem with supranotch disease is ITF clearance or compartmental resection would be difficult in supranotch disease, or it becomes an unresectable disease.
So what do we do in a borderline resectable cases?
So borderline resectable cases, neoadjuvant chemotherapy can be given where it will reduce, or which will help for a clear getting clear margins or better margins post NACT for such cases.
So do we have any evidence for this?
Sir, I don't know. Sir, I would read on that, sir.
No. So basically, in borderline operable cases, yes, we are trying NACT, but there is no as such level 1 evidence. There is a paper from TMH article, TMH itself, where
Yes.
there was a study conducted in TMH, where they have seen in 721 odd patients, I guess, and they have given a criteria for borderline resectable. We tried to give NACT in those cases.
Okay, sir.
Okay.
Yes, sir.
It's not mandatory that in all borderline resectable cases we need to give NACT, but yes, we can try. And even far away from Liao, there is a recent paper from TMH itself. Manish Mayer from TMH itself has published on supranotch diseases. So please read that. That is also a very good paper.
Yes, sir.
So you'll get a updated about supranodge and infranodge, or what is the outcome of those patients. Okay.
Yes, sir.
Well presented, Bhavya. The organizers need to wind up now.
Thank you, sir.
Very nice presentation. Very well.
There are actually a few questions and discussions going on in the chat box. I would like to invite Dr. Aseem to continue the discussion and complete the discussion, and then on we can go to vote of thanks. Dr. Aseem, please.
Okay, so this was a very good session and discussion to start with. I am happy because the residents are able to discuss, they're able to put up the points. And as the session progresses, all of you will be able to do much better and everybody is going to improve with this. I would request that all the residents across all centers that are there, you can write to us, you can ask us, and you can make a presentation for the next time. So every Thursday, this is going to happen, every alternate Thursday. So you can come up and make a presentation here. And this is going to improve your presentation skills. As you present more and more, you'll excel at presentation and develop a better idea to give examinations, and also to see how you discuss in various conferences, in the panel discussions and everything. So this is a very good platform for all of you. And that is why I encourage all the residents to present whenever possible. Whenever you get an opportunity, please present here. Thank you, Bhavya, for the nice presentation.
Thank you, sir.
If anybody would like to make any comment, please.
I think a very good point was raised by Deepak sir about second primary tumor and second field tumor. I would be glad if you would like to say something about the topic. Deepak sir. Hello.
I'd like to over to Dr. Ravi for the vote of thanks.
Okay.
And I would also like you to invite for the next session, which is going to be held on 13th of January. And the presentation will be on the carcinoma of the tongue.
So, as already told by Dr. Aseem that the next session is going to be on 13th, I would like to thank all the eminent faculty members who have taken their time off today for this academic session. And I would also like to thank Dr. Bhavya for this wonderful academic and wonderful presentation.
Thank you, sir.
I would especially like to thank Dr. Pankaj sir, Poonam ma'am, Devendra sir, and Dr. Kranti sir for coming here today and giving his time for this event today. Thank you so much. I think we can end. Acha, I think Deepak sir has come. I think he would like to speak on the topic.
Yeah, there's some problem with my network, so I wasn't able to communicate. I would strongly urge the residents to read Bracquis's paper, which was published in Head and Neck, where they have looked at clonal migration versus in situ genetic changes of that population, and what is the distance that clonal population can migrate. So they have some changes made on what is a SFT, what is an SPT. So I would encourage the next presentation when we have on tongue cancers. I think it'll be a very relevant discussion because that is more appropriate for tongue carcinomas than buccal carcinomas. And the other thing that I wanted to encourage the residents is that all of you should learn the principles of reconstruction very strongly, because trying to close a 4 centimeter mucosal defect is impossible. It's just not possible. And trying to retain a split skin graft in the oral cavity also is impossible. and you'll be resecting the buccal pad of fat anyway with your margins. And buccal pad of fat will anyway heal with secondary intention for the patient. So if you leave any mobile mucosa to heal by secondary intention, you're going to cause trismus. So you have to be very sure, especially when you plan your cases, where to use fixed mucosa, where is mobile mucosa, because in the hard palate, you can put muscle or a skin graft. It doesn't matter because the mucosa is not mobile. But if you try doing that for a tongue or floor of mouth or a buccal mucosa lesion, you're going to cause a lot of secondary intention healing. So, and I learned a very nice point from Kranti. He said that they have been doing lateral arms to the submental vessels, which I have never thought of. So it was a very fulfilling discussion. The next tongue presentation, I will talk about the extension to Bracquis's paper. There's a couple of other papers which have come for genetic level analysis. So I think the next discussion will also be as fruitful as this one. So thank you very much, Azim and Ravi. You're very kind and I really enjoyed the presentation. Thank you so much.
Thank you, sir, and thank you to all the eminent faculties over there. Thank you so much for coming today. Thank you. I think we can sign off now. Thank you.
Thank you.
Thank you, Ravi. Thank you, Asim.
Thank you, sir.
Thank you, sir.